Hi, I'm Catherine DeRusha, and this presentation will focus on cardiac amyloidosis in the older adult population. Cardiac amyloidosis is an etiology of heart disease in the older adult population. Improvements in imaging and diagnostic tests have made it easier to diagnose this condition, although it still remains underdiagnosed due to its general manifestations that are very similar to other common heart diseases. This presentation will go over pathophysiology, how it presents in the older adult population, diagnosis, medical treatment, nursing education, and additional educational resources. This presentation will begin with a review of normal cardiac physiology to provide a basis for comprehending the impact of amyloid production on the myocardial function. Next, we will review the pathophysiology of cardiac amyloidosis, which includes how misfolding proteins build up in myocardial tissue and make function poor. We will discuss risk factors, common patient manifestations, clinical signs, and diagnosis. Finally, this presentation will go over current treatment plans, nursing interventions, and overall patient education. What is cardiac amyloidosis? Cardiac amyloidosis is an infiltrative cardiomyopathy marked by accumulation of misfolded protein fibers within the myocardium. Amyloid fibrins form when protein that normally moves around the body changes shape, causing them to fold incorrectly and clump together into deposits that cannot be dissolved. These deposits build up in the heart tissue and slowly change the normal structure and function of the heart muscle. The first type is transthyretin amyloidosis, abbreviated to ATTR, which occurs when transthyretin protein is unstable. This condition can manifest as a hereditary variant resulting from genetic mutation or as a wild-type ATTR. The second type, immunoglobulin light chain amyloidosis, abbreviated AL amyloidosis, is caused by a plasma cell disorder that makes abnormal immunoglobulin light chains. Amyloid infiltration leads to thicker ventricle walls, less flexible myocardium, and problems with filling the ventricles. This can cause restrictive cardiomyopathy, arrhythmias, and heart failure. Normal cardiac physiology. The coordinated process of systolic contraction and diastolic relaxation are what keeps the heart working normally. The ventricles contract during systole to push blood into the pulmonary and systemic circulation. The ventricles relax and fill with blood at low pressures during diastole. The myocardium is somewhat elastic and flexible, which allows the ventricles to expand and to hold blood volumes efficiently. Several physiological mechanisms support this function, such as calcium regulation and the extracellular matrix, and proper myocardial perfusion. Effective ventricle filling during diastole guarantees sufficient stroke volume and cardiac output, especially under heightened metabolic demands. In cardiac amyloidosis, the gradual buildup of amyloid fibrils interferes with these normal processes by making the heart less flexible and making it harder for the ventricles to relax. Pathophysiology. Amyloidosis is a systemic condition, but when affecting the heart muscle, it is considered cardiac amyloidosis. The pathophysiology of cardiac amyloidosis includes the gradual buildup of amyloid fibrils within various cardiac structures. These deposits build up within the space between the heart muscle, the coronary microvasculature, the heart valves, and the conduction system. The walls of the ventricle get thicker and stiffer as amyloid fibrils build up. This causes restrictive cardiomyopathy, which means that the ventricles can't relax and fill up properly during diastole. When the ventricles don't fill up properly, the pressure inside the heart increases, the stroke volume decreases, and the ability for exercise tolerance decreases. Amyloid infiltration of the conduction system may also interfere with elastic signals in the heart. Patients may experience numerous arrhythmias as a result. These pathological changes can lead to worsening heart failure and a decrease in functional capacity overall. Risk factors that can cause cardiac amyloidosis. The most common risk factor being an older adult, especially for wild-type transthyretin amyloidosis. Additionally, genetic factors influencing hereditary forms of transthyretin amyloidosis, with particular mutations occurring more prevalently for specific populations. Additionally, environmental factors do not directly influence amyloidosis. However, they may affect the interpretation of systems. For example, musculoskeletal issues or a lower tolerance for exercise may be due to older adults in cardiac amyloidosis. Also, social factors that affect health, such as having access to special cardiology services and advanced diagnostic images, can delay diagnosis. Diagnostic delays are common in the older adult population. Typical patient profile. Patients diagnosed with transthyretin amyloidosis are generally over 70 years old and male. Numerous patients also exhibit a prior history of heart failure with preserved ejection fraction, left ventricular hypertrophy, atrial fibrillation, or valvular heart disease prior to the diagnosis of cardiac amyloidosis. Patients often report extracardiac symptoms that occur several years prior to cardiac involvement. Additionally, a history of bilateral carpal tunnel syndrome, lumbar spinal stenosis, or tendon rupture result in amyloid deposition in connective tissue. Signs and symptoms. Individuals with cardiac amyloidosis generally present clinical signs related to restrictive cardiomyopathy and diminished cardiac output. This includes dyspnea, fatigue, decreased exercise tolerance, and peripheral edema. Patients may also exhibit signs of right-sided heart failure. This includes abdominal distension or ascites. Arrhythmias are also common, especially atrial fibrillation, which can cause palpitations or a fast ventricle response. Additional problems include pre-syncope or syncopal episodes. Some patients may have problems with autonomic nervous systems, which can cause orthostatic hypotension or dizziness. The diagnostic assessment for cardiac amyloidosis includes labs and imaging analysis. Lab results often show higher levels of natriuretic peptides, for example, BNP or NT-proBNP, which indicates that the heart wall is under more stress. Persistent elevation of cardiac troponin levels may occur due to ongoing myocardial injury. ECGs may show low QRS voltage, problems with conduction, or atrial fibrillation. Electrocardiograms frequently demonstrate augmented ventricular wall thickening, dilated atria, and compromised diastolic function. Cardiac MRIs can detect myocardial infiltration via late gadolinium enhancement patterns.